This is Jose Merino, Editor-in-Chief of the Neurology family of journals. The Neurology podcast provides practical information to neurologists and other clinicians to help them provide better care for their patients. Thanks for listening and have a great week.
Hi, I'm Tesha Monteith with the Neurology podcast. Just out in Neurology is a paper that I really enjoyed reading called Combined Impact on Migraine and Pregnancy-Induced Hypertension on Long-Term Risk of Premature Myocardial Infarction and Stroke. With me to discuss is the lead author, Cecilia Hvitfeldt Fuglsang, a registrar at the Department of Clinical Epidemiology at Aarhus University and Aarhus University Hospital in Denmark. Cecilia, thank you so much for being on our podcast.
Thank you so much for inviting me.
I really enjoyed your paper. I read it and I said, you know what? We need to get her on. We need to understand this more. I've done some research in migraine and cardiovascular disease and stroke, and it just amazes me that a lot of the literature is just very consistent. So why don't we just start off with some general background? Why did you set out to do this research?
Migraine, and in particular migraine with aura, and also pregnancy-induced hypertension are risk factors for stroke and myocardial infarction. But what some may not know is that actually there was a study that published around 20 years ago that showed that women with migraine and hypertension in their pregnancy had a much higher risk of ischemic stroke than what we would expect. So if we had summed the risk due to migraine with the risk due to hypertension in pregnancy, then we would not find this very strong association that they did. So basically in this study, we wanted to see if we could reproduce these findings.
Okay, great. So why don't you tell us a little bit about the specific aims of the study and the study design?
This was a cohort study conducted in Denmark where we used routinely collected data from nationwide registries. The overall aim was to examine both the separate and the combined impact of migraine and pregnancy-induced hypertension, or PIH as we abbreviated in the paper, on the risk of myocardial infarction and stroke. And so more specifically, what we did was that we included all women in Denmark with at least one singleton pregnancy during the period of 1996 to 2018. And then we divided these women into 4 groups or 4 cohorts. So women with only migraine, women with only PIH, women with both migraine and PIH, and finally women with neither condition. And then we followed the women from the date that they delivered their child and until they had a stroke or myocardial infarction, immigrated, died, or the study period ended. And then used these data to calculate the risk of stroke and myocardial infarction for each cohort.
So tell us about how large the study was, and you can also tell us a little bit about the database.
In total, I think we had around 1.4 million women included in the study, so a very large study. And that is, I think, one of the very nice things here in Denmark is that we have these nationwide registries. So basically, we can follow everyone from the day that they are born until they immigrate or die. And each time one of us goes to the hospital, it is recorded in a registry. When we redeem a prescription at a pharmacy, it is also recorded, and it is at an individual level. So it's really a unique opportunity to conduct these types of studies.
And why don't you also tell us a little bit about this endpoint, this composite endpoint, MACE?
As you probably know, stroke and myocardial infarction, fortunately, is not that common within this relatively young age group. So instead, we used a composite endpoint which consisted of fatal and non-fatal myocardial infarction and stroke, and that is what we called MACE, Major Adverse Cardiovascular and Cerebrovascular Event.
What were some of the major findings of the study when you compare these cohorts?
As we expected, we saw that migraine and PIH were separately associated with an increased risk of this premature MACE event. But what we did not expect, based on the existing literature that I mentioned in the beginning, was that when we looked at women with both migraine and pregnancy-induced hypertension, their risk of this cardiovascular event was similar to that of women who had only PIH. So that was in contrast to the previous literature.
Just looking at migraine alone, migraine compared to those who did not have migraine, did we see any increased cardiovascular risk?
Yeah, and that is, as you also mentioned in the beginning, that is what we consistently find in the literature. That was also something I had looked at in one of my previous studies, that actually women with migraine have a higher risk of both stroke and myocardial infarction.
What about things like increased lipids?
I can't recall at this moment. I know that there are also studies showing an increased risk of atrial fibrillation, venous thromboembolism.
So let's just talk a little bit about the baseline characteristics. Were there increased cardiovascular risks in those with migraine?
What we see in the baseline characteristics was that women with migraine tended to have a higher BMI. They also tended to have some of the comorbidities that are known to be associated with cardiovascular disease were also somewhat more prevalent among women with migraine.
And I know you controlled for that. And then let's also talk about aura.
Unfortunately, in our data, we don't have information on aura status for all of the women. In fact, not that many of the women, because most of the women with migraine were identified using prescription data.
It looks like about 9% of
Yeah,
those with migraine.
yeah. And that's because the majority were identified using these prescription data, where we don't know whether it was migraine with aura or migraine without aura that triggered the prescription.
So maybe a little bit of underreporting there.
Definitely, yeah.
And then you also did some fancy sensitivity analysis.
Yeah, we did two sensitivity analysis. So in the first one, migraine remained one exposure, but the second exposure this time around was preeclampsia and eclampsia, so the more sort of severe conditions of pregnancy-induced hypertension. And we did that because they were more severe exposures that we know are more strongly associated with cardiovascular disease, but also because the hospital diagnostic codes that we use to identify these diseases are perhaps somewhat better for preeclampsia and eclampsia than for gestational hypertension. And then we did a second sensitivity analysis. In the main analysis, we excluded women with chronic hypertension because they would not be at risk of developing gestational hypertension. But in this sensitivity analysis, we included them, but then adjusted for hypertension instead. But the findings were more or less the same as in the main analysis for both sensitivity analysis.
And then were there any surprises in the study? And let's also talk about potential confounders.
My main surprise was that we did not see this hugely increased risk of cardiovascular disease among women with both migraine and PIH. But I would say thankfully for that. In terms of confounders, of course, there are a lot of potential confounders, a lot of risk factors for cardiovascular disease that we need to consider. Some of these comorbidities, we adjusted for those. But then there's things such as lifestyle, and we had information on smoking and adjusted for that. But then there are other things such as physical activity or drinking that we did not have sufficient data for. So there could be some residual confounding there.
And then in your paper, you mentioned that PIH is pretty low in Denmark.
Mm.
What do you think the generalizability is maybe in other populations where it's much higher?
I would have to say, hope that someone else will conduct a similar study in other populations, because it is very low. And I know, for instance, in the US, you have somewhat higher rates of PIH, and the results may look different.
We also don't have your kind of
Yeah.
database, but we do
No.
have some, we have some surrogate ways of doing things here. Well, let's also talk about the strength of your study and what you think the limitations were.
I think the major strengths are the data sources, right? Being able to follow everyone and include all these women. I mean, basically including every woman in Denmark who had a singleton pregnancy in the study period. It really minimizes the risk of selection bias. I am more concerned about misclassification, misclassification of migraine in particular, because for us to identify a woman with migraine in this study, that person would have had to have seen a physician. So perhaps we're not capturing the women with less severe types of migraine who may not go to see their GP, for instance.
And we always like to think about how these important papers can make us better neurologists. And so, based on the findings of this study and some of your work in your PhD, how should we be managing our patients or women that have migraine and to further reduce risk of potential cardiovascular complications down the line?
I think that is really the important question. And I think, unfortunately, that is something where we still really need a lot of literature because we don't know why migraine is associated with stroke and myocardial infarction. There are a lot of theories, but we cannot say for sure. So what we can do at the moment is be mindful of this risk and make sure to optimize treatment for modifiable cardiovascular risk factors. So, help these women quit smoking if they're smoking and treat hypertension and so on. I think it will be interesting to see what happens within this research area because I actually recently saw a small pilot study where they looked at preventive migraine treatment and how it affected markers of oxidative stress and endothelial dysfunction, which may lead to stroke and MI. And it may be actually that if we optimize this treatment, we can reduce the risk, but this is still something that we need to investigate further to say for sure.
And also, as you mentioned, we didn't have the exact phenotype of the most high-risk group of migraine. Is it those with frequent aura, those with high-frequency untreated migraine?
Exactly.
And were you able to say anything about triptan use?
So we didn't look at that specifically, but a large proportion of our population of women with migraine were identified by use of triptans. So they would be triptan users, at least early on in the study period.
We should also talk about antihypertensive medications and how that may have come into play.
I think the reason why we see in particular those with migraine being on these types of medication is that it's preventive migraine treatment as well. So could this perhaps diminish their cardiovascular risk? I don't know. Or is it actually because they're being treated for something else and in fact their cardiovascular risk profile is already higher than the comparison cohort? I don't know.
Yeah. And so what is the next step for this study?
I'm still working a lot on migraine, and I've actually started to look more into also what is the importance of migraine on things such as socioeconomic position. And so I'm trying to broaden the horizon a bit and look into different aspects of migraine because I know it is a disease which affects people's lives substantially and not just cardiovascular risk, but everything else in these people's lives.
Yeah, so thank you so much for sharing your work with us.
Yeah, sure. Thank you for having me.
I look forward to seeing a follow-up to this study. Thank you as always for listening to the Neurology Podcast.
This is Stacey Clardy, your podcast editor. If you've enjoyed the podcast, please take a few moments to subscribe, rate, and review the Neurology Podcast through Apple Podcasts, Google Podcasts, Spotify, or wherever you listen. And remember, you can always head to neurology.org/podcast for our full list of past episodes, or you can also search by keyword in your podcast app for any neurology-specific topics you want to learn about.